Welcome to the Speaking of Women's Health podcast. I'm your host and author of the Cleveland Clinic Guide to Menopause. And this is chapter 7 of my 2009 book, which I'm updating as I go along. This is February 2023. Chapter 7 is Hot Flashes and Night Sweats. If there's one line that screams menopause, inevitably a hot topic in personal conversation among midlife women, it's I'm having a hot flash. There's no mistaking the sudden, intense wave of heat, rapid heartbeat, and depending on the severity, dizziness, sweating, nausea, and a feeling of weakness. Surely you're going to suffocate. Someone, please open a window. You flap your arms wildly in an attempt to fan away the perspiration that first collects on your upper lip, then your forehead and neck. Sometimes it's an all-out soaker. This is never good, especially if the episode occurs during a board meeting or leaves you with soggy sheets in the middle of the night that you have to change. Hot flashes are even more upsetting if they happen 30 or more times a day, as they did with Linda. I've known Linda for more than 10 years, and before she began taking estrogen therapy, her hot flashes greatly interfered with her everyday life. Just listen to her description. I'm the chief financial officer of my company, and my episodes are downright embarrassing and horribly frequent. I cannot get through a 1-hour meeting without arousing the concern of others at the table. I turn tomato red. My temperature rises to what seems like 30 degrees. I could swear I'm in the Sahara Desert. This lasts for up to 5 minutes, and then I break into a sweat and my face loses all color. This can happen up to 30 or more times a day. It's so disruptive at work, and it's disturbing at night when I'm trying to sleep. I just can't get a good night's sleep or any rest. Every time I have another flash, I wake up, my heart pounds. Sometimes I feel as if someone is smothering me with an electric blanket cranked up to the highest setting. I can soak the bed with perspiration. After particularly bad episodes, I have to change my nightgown and my sheets. Well, Linda's case is extreme, but most women experience hot flashes to some extent during the years of perimenopause and menopause. Often occurring at night, the hot flashes are uncomfortable and almost are always accompanied by some perspiration, which is the body's natural coolant. I prescribed hormone therapy for Linda, and her frequent soaking flashes were history. So what exactly is a hot flash? Well, it's a discrete, intense episode of heat that starts usually at the chest and neck, flows to the head, and lasts several minutes. Flash is the key word. It happens suddenly and lasts only minutes. A flash is accompanied by perspiration and is an entirely different sensation from just feeling hot all over. Some women who complain of hot flashes are actually warm all the time. They tend to perspire easily, so they open a window because the room feels stuffy. They may turn up the air conditioning and then point to this as a menopausal symptom as the culprit. I'm having a hot flash, they insist, when they've really just entered a room with a slightly elevated temperature that pushes them from just being warm to sweating. If you're overheated all the time and you're not flashing, you may have another reason for heat intolerance. Some very overweight women simply have too much insulation, as if they're wearing a thick winter coat in the summer. There are other reasons unrelated to menopausal changes that can cause women to experience hot flashes. Many women with diabetes discover that condition actually damages their autonomic nervous system, which is responsible for such bodily functions as perspiration and temperature regulation. People with over or underactive thyroids can experience temperature fluctuations for similar reasons. The creepy crawlies. In very rare cases, hot flashes can feel like insects crawling under and all over the skin, especially on the scalp and arms. Only a handful of women in my now 3 decades, not 2 decades, of practicing women's health have cited this feeling. They think they're going crazy when they have this creepy crawly sensation. which may be followed by a typical hot flash. The medical term for this is tactile hallucinations or formication, and the best treatment for most women with this condition is, in fact, hormone therapy, since these altered skin sensations may be related to drops in estrogen. What causes a hot flash? Well, we know what a hot flash feels like, so why is your body unstable and cranking up the heat? Why do hot flashes, or particularly low or up and down fluctuating levels of estrogen like in perimenopause, occur and cause these symptoms? A flash versus flush. Well, when the hot flash produces visible redness in the face and neck, we call them a hot flush. The flush refers to the redness itself. This is how it happens, and we certainly have a much, much better understanding of hot flashes based on finding hypertrophy in the KNDy neurons in the brain in the hypothalamus, the temperature regulating area. This has certainly given rise to a few substances which are being investigated and hopefully will be on the market by the time you listen to this podcast, or certainly, hopefully in the year 2023 and beyond. So when you have a drop in hormones, it signals the body's thermostat region, which is like the temperature regulating area in the hypothalamus. Until menopause, estrogen really helps regulate the body's temperature, keeping it within its comfort zone and preventing us from overheating or breaking into sweats after very small ambient temperature shifts. But without the help of estrogen or a stable level of estrogen, some women whose brains are wired as such become very sensitive to the most minor temperature changes that most of the rest of us just don't notice. The brain says, oh no, it's getting hot in here. So reacting to the brain's message, the heart pumps faster and blood vessels in the skin dilate to circulate more blood and disperse the heat, and the sweat glands gear up. With the right level of stable estrogen, the brain's thermostat registers the message that, oh, the temperature's fine in here. But many women's brains are very overly sensitive to this fluctuation in hormones, which are in perimenopause, or just the absolute drop in estrogen, which happens in menopausal and postmenopausal women, and, oh, by the way, can happen in men who lose their androgens because testosterone is converted to estrogen in men. Now, there are also some non-hormonal factors that can affect the sensitive brain thermostat, adding to disruptive hot flashes. If your best friend's not having hot flashes, you may be wondering, why me? Well, some women are just simply more sensitive and wired, just like some women have hot flashes and others don't. So, if your brain is sending out warnings that something is out of balance, it's really important to pay attention to it. We know from blood flow studies to the brain that during a hot flash, there's dramatic changes in brain blood flow, similar to what we see in Alzheimer's. So hot flashes are not good on the brain or the cardiovascular system or your sleep or your mood or your sense of well-being or confidence level. So just like women who are prone to migraines, which is about half the population, women who experience moderate to extreme hot flashes have brains that are programmed to be a bit more sensitive to changes and fluctuation. Fast fact: an excess of body weight can cause women to suffer more from hot flashes, both in frequency and severity, than they would if they were at a normal body weight. To combat this, some experts recommend that even normal body weight women approaching perimenopause and menopause work hard to lose 5 to 10 pounds prior to menopause, to account for the fact that most of us are going to gain 5 to 15 pounds during this life stage. I mean, it's one thing to gain 25 or 30 pounds and get a baby at the end of it, but at menopause, 5 to 15 pounds on top of baby weight is not a happy weight. And heavier women who are at increased stress, and women who don't exercise regularly may tend to have more intense hot flashes. That being said, you can be slender, exercise daily, enjoy yoga, meditation, deep breathing, have a relatively stress-free life, and still have severe hot flashes. So while lifestyle changes and healthy living go a long way towards easing the transition into menopause, that's not enough for all women. And it burns me up, no pun intended, or maybe the pun is intended, when I meet women whose doctors have just dismissed their complaints of hot flashes, telling them, oh, it's normal, women have done this for millennia, oh, just go exercise more, just take a few deep breaths, or I even had one patient tell me a physician told her to put her head in an ice box. So just as doctors can treat migraines, we can treat hot flashes with hormonal and non-hormonal options. So let's go over the causes and triggers of hot flashes. Certainly environmental triggers such as stress, stuffy rooms with poor air circulation, warm, humid weather may set off your temperature and cause hot flashes. Other culprits in some women include caffeine, alcohol, spicy foods, tight, constricting clothing, heat, smoking cigarettes, and nicotine. Some women can find that they can control their hot flashes in large part by avoiding some of these triggers. Tracking your triggers. To track down what specifically might be triggering your hot flashes, try recording when they occur and note any patterns. Carry a little spiral notebook for a few days, or jot down what you're doing right before the flash starts, or just type it into your notes in your cell phone. Did you have a cup of coffee or a glass of wine? Were you stressed out? Were you wearing tight, constrictive polyester clothes? See whether there's a common theme and then work to eliminate the trigger. To narrow the list of possible suspects, try recording when they occur and look at patterns. Are you dealing with a stressful situation? Were you asleep? Did you notice it right after eating something? If your episodes are mild and moderate, you can try some cooling techniques like layered cotton clothing, sipping a cold drink, arriving at meetings early so that you get choose the seat near the vent, window, or fan. If you know that stress is a trigger, practice deep breathing exercises to relax. Wearing cotton, linen, and rayon clothing instead of synthetics, silk, or wool can be helpful. Exercising daily. And certainly cool packs such as things you can slip into your pillow or a cool cloth around your neck, or sometimes those little handheld fans. They even make fans to put at the foot of your bed, can be helpful. Night sweats. Generally, hot flashes tend to be more severe at night, which tends to be the worst time to get them because you're trying to sleep. Not only are you hot and bothered, but you're losing sleep night after night. So sleep loss compounds fatigue. Thus, it affects your mood, then your work performance, your overall health, and your relationships. In Chapter 8, we're going to talk about ways to get a good night's sleep. So let's focus on the timing. Why do you flash at night? Well, your body temperature normally responds to a few notches as you sleep. It dips. When your body's cooler, you actually are sleepy. The small decrease is a big deal if you lack estrogen. As your body temperature drops slightly, your brain says, oh no, time to turn on the heat. It's getting too cold in here. The result is a hot flash, which then becomes a night sweat when your cooling system triggers the sweat glands into action. When you wake up hot and then wet, you eventually get cold. Can I prevent night sweats? Well, sleeping in a cool room about 65 degrees with a fan, and actually wearing socks can help regulate your body temperature while you sleep. Many women think that putting socks on will just make them hotter, but it's actually not the case. If you warm up your peripheral extremities like hands and feet, your body temperature may be more stable. And when your body temperature is more stable, your brain does not send out messages to your body. If night sweats are a problem, try some additional tips. Buy cotton sheets instead of synthetics. Wear natural fibers like cotton to bed. If your partner likes to sleep with layers of blankets, buy twin-size covering for sleeping so that you can both be comfortable. Lower the thermostat to 65 degrees before you go to bed. Invest in a ceiling fan, air conditioning, or even a handheld battery-operated fan that you can flutter in front of your face. Purchase a chill pillow, which is a much cooler pillow that you can lay your head on or hug during a hot flash. Treating hot flashes. Because menopausal symptoms can be bothersome to downright disruptive, thankfully we have several treatment options. Prescription therapies include menopausal hormone therapy, because lack of estrogen or marked fluctuations can cause hot flashing. Replenishing just a bit of your lost estrogen with hormone therapy, basically to a level of what a man has, or what is a early follicular menstrual level, it can really stabilize symptoms. This is a very effective gold standard treatment for most women within 10 years of menopause who are having these so-called vasomotor symptoms. And despite the media assault on hormone therapy, the fact is the risk of hormone therapy for short-term 10 years are minuscule. And actually, most healthy women who take hormone therapy actually live longer. So timing is key, and so is periodic reevaluation. And one thing I tell women is just because you're a woman, you don't have to be a martyr. And there's no time limit to feeling well or enjoying your life. There's one chance in 1,000 that you could have some side effects or consequences. So that means the vast majority of people do very well. They like the way their skin looks, their sex drive improves, their sleep is better, their energy's up, they don't have a dry vagina, bone health improves, and yes, thankfully, their vasomotor, hot flashes, and flushes subside. The North American Menopause Society, menopause.org, does post updated statements on the use of hormones, estrogen, and progestogens in perimenopause and menopausal women, and classifies risk into rare, very rare categories. And it gives some compilation of the latest research into the benefits and risk of hormone therapy. And the best website to empower you to be strong, be healthy, and be in charge, and give you information on hormonal and non-hormonal therapies, as well as breaking health news, is our nonprofit, speakingofwomenshealth.com. So if you haven't already signed up for our free newsletter and health tip, please do that. And please bookmark the website on your phone and your computer. So for the average woman with hot flashes, I might prescribe hormone therapy for 2 to 3 years until symptoms subside. And if she's comfortable, or if she's having any kind of symptoms of breast tenderness or spotting or bleeding, we would evaluate that and potentially lower the dose. But there's no reason to just wean hormones. In fact, research out of Finland shows if you're under age 60, even under age 65, if you look at the women who are on hormones and then taken off after 5 years or 10 years, or the women who continue hormones, the women who continue hormones, as opposed to being the ones that are abruptly taken off, actually have less heart attack and stroke, because 50% of all women who flash, who take hormones for a period of time, who then are not flashing, who decide to stop therapy, half of those women's flashes will come back. And that really doesn't matter whether you wean the dose or just stop. And so those flashes are a stress to the system. So when doctors erroneously, or other healthcare clinicians, tell women, oh, you've been on it for 5 years, you need to come off, some of those women who come off are actually harmed. So there's no other hormone that we say, oh, you've been on insulin for 5 years for your diabetes, you need to come off. No. Now, if you get a new pancreas, because you get a pancreas transplant for your type 1 diabetes, well then hallelujah, your body's making insulin. But we are not doing ovarian transplants. So once you lose your estrogen, you'll lose your estrogen. I have had many women in my practice who've been on hormone therapy for decades. And unfortunately, there is a small percent of women who continue to flash their entire life. Most women, it's for a few years, and certainly under a decade. My goal is, if you're on hormone therapy and doing well, to try to at least be on it for a decade to push the aging curve out to the right and extend the lifespan by a few years. And just because you reach a certain age doesn't mean you should be cut off. Certainly reevaluated, new options, perhaps lower doses, maybe after age 65, transdermal. But when hot flashes disrupt a woman's ability to sleep, to function, to participate in daily activities, just like they did with Linda, I might suggest hormone therapy for a long-term solution. And for women who continue to have symptoms when their hormone therapy is even slightly reduced, or women who've decided to stop their hormones and have their symptoms recur, I also recommend it as a long-term solution. But I still want to see my patients yearly and reassess. In the wake of the Women's Health Initiative, which I'll talk about in detail in Chapter 10, unfortunately, women for the last 20 years have been inappropriately told that all traditional prescription therapy, hormone therapies are risky. And so lots of women have turned to alternatives. Some women have been hoodwinked when they've been told that, quote, natural bioidentical hormones compounded individually are just completely safe and risk-free. Okay, nothing is 100% safe and risk-free for everyone. Not shrimp, not cashews, and not a hormone or an herb or a non-prescription drug or other prescription drugs. Everything has potential risk and benefits, but the risk-benefit equation is so much more favorable for most healthy women within 10 years of menopause. And even women that are older or have health risk, when you compare it to other drugs that we commonly prescribe, whether it's cholesterol-lowering medicines, diabetic medicines, antibiotics, the bar to which hormone therapy has been set to, I think, is incredibly unfair. So any hormone, including the ones that are mixed up on the premises by a compounding pharmacist, carries potential risk. And we have an appendix in this book, and we have a lot of information on our website about compounding pharmacies. And I certainly compound prescription. Well, I don't compound it, but I prescribe compounded hormones that our compounding pharmacist mixes up. But it is technically illegal to write a prescription or compound a prescription if it's commercially available. Now, if patients are allergic to something that's in the prescription, like natural progesterone in the form of prometrium, is mixed in peanut oil, and some people are allergic to peanuts, well, then that would need to be compounded, perhaps with safflower oil. If you need a different dose or a different route of administration. So I much prefer to prescribe medicines that are regulated because there's a quality control factor to it. It's just like I buy pasteurized milk. But if I had no access to pasteurized milk, I'd have to compromise my standards and maybe just get it from a local person who owns a cow. Just like I want U.S. grade A inspected meat. But again, if there was no way to get to a grocery store and buy that, and it was nothing, or getting meat from someone who had just, slaughtered an animal, well, then you would have to settle for a lower standard. And that's the way I like to frame it. It's not that compounding is safer or better. It's different, and there may be reasons to do it, but it is not necessarily the optimal, especially if you don't know the compounding pharmacist and what their standardization is. Antidepressants, SSRIs, NSRIs, it certainly has been noted a handful of antidepressants have been prescribed off-label for treatments of hot flashes. Off-label means that the drug was approved by the FDA for a different reason than why you're taking it. We actually have had the first non-hormonal antidepressant in a non-depressing antidepressant dose, paroxetine, 7.5 milligrams Bristol, be the first one in that class to be FDA approved to treat vasomotor symptoms. And that's nice because it's a lower dose than, say, the 10 milligram or 20 milligram dose of paroxetine or Paxil that people may take for depression, which can have some weight gain or sexual side effects. But um, these medications are metabolized in the liver and can affect cancer treatments and cancer preventive medicines like tamoxifen. And certainly antidepressants in adults have benefits for treating some anxiety and mood disorders, but the degree to which they improve hot flashes are not on the same level as hormonal therapy. And even if they stop hot flashes, they don't do anything to help the dry vagina, the thinning bladder, the thinning hair, or prevent osteoporosis. And like I mentioned, if you're a breast cancer survivor on tamoxifen or taking tamoxifen simply to reduce your risk of breast cancer, then we would not recommend paroxetine, Paxil, or Brisdel to treat hot flashes because it reduces tamoxifen levels in women by affecting the metabolism. If a patient's not depressed but would rather be taking an antidepressant instead of hormone therapy, sometimes I use low-dose SNRIs off-label like venlafaxine or Effexor. And venlafaxine is the active isomer of desvenlafaxine, also known as Pristiq. And even though Pristiq is not FDA approved to treat hot flashes, it has been studied as such, and it also helps with anxiety and sleep. If you're on a medicine like Effexor, which is venlafaxine, then the doses that are used are 37.5 to 75 milligrams, which may not be enough to treat anxiety or depression. And if you go up higher on that Effexor dose, then you may treat the mood, but not the hot flashes. So that's why in women who need both hot flash and mood treatment, I prefer desvenlafaxine. And there's lots of other treatments like Megace, megestrol acetate, which is a synthetic progestin. It has been associated with some weight gain. It has been used in women with breast cancer. Catapres or clonidine, which is a blood pressure medicine, is sometimes used to prescribe hot flashes in women with high blood pressure. Neurontin gabapentin is an anti-seizure medicine that is sometimes used for sleep and pain and may help with hot flashes, but at higher doses can cause some dizziness and fluid retention. Ditropan is a medicine used for overactive bladder, and in some women actually helps reduce hot flashes. And we're really looking.
We'll be back after a quick break.
Hey, quick question for you. Are you someone who wants to be fit, healthy, and happy? And what if I told you you could get your dream body by simply just listening to a podcast? I'm Josh.
And I'm KG, and we're the hosts of the Fit, Healthy, and Happy podcast.
Listen, we get it. Fitness isn't easy. Carbs, no carbs.
Just stop, okay? It doesn't have to be that complicated. And that's why we made this podcast. We get straight to the facts so you can become your best you.
So the way to check us out is click the link in the show notes or search Fit, Healthy, and Happy podcast on any of the major podcast platforms. We'll see you soon.
To getting the candy neuron antagonist, fezolinetant or Fezo, hopefully in a 45 milligram daily dose, and elazenitant, which is a candy neuron receptor 1 and 3 inhibitor in the future. So breast cancer and hot flashes. Non-estrogen options can work. And unfortunately, some cancer treatments, particularly chemotherapy, can wipe out the ovarian function, forcing some women into a premature or early menopause. When that happens, estrogen levels drop suddenly, and hot flashes can sometimes be very severe. And again, not all women are wired to flash, so it's not necessarily a given. And generally, hormone therapy is not generally appropriate for women undergoing active treatment for breast cancer or for women taking tamoxifen, or women on aromatase inhibitors such as aromacin, which is exemestane, or arimidex, which is anastrozole, or Femara, which is letrozole. This is when we usually look at non-estrogen alternatives. We may use low doses of that venlafaxine. We may, in the future, use the candy neuron inhibitors, specifically which focus on that part of the brain that is involved in the flashing. What about herbal remedies? Some women prefer a non-prescription approach, And there are some options, but none are approved by the FDA. And we don't really have long-term therapies. You may want to listen to the podcast interview with Dr. Sobia Khan that I did on our Speaking of Women's Health CME channel, or the one with Dr. Mary Jane Minkin, who runs madameovary.com, and she's at Yale and specializes in breast cancer survivors who have hot flashes and sexual dysfunction. And she has a lot of experience in using black cohosh remifemin and using other herbs that may help the hot flashes. But please remember, even if you get symptom control with your hot flashes or hot flushes, that doesn't take care of all the issues of menopause. Specifically, it won't prevent bone loss, although we have lots of options for that are not hormonal. And it won't treat the symptoms like vaginal dryness, painful sexual activity, decreased sex drive. And thankfully, we have some options for those. So black cohosh. In Germany, it's a prescription herb. And some randomized trials suggest that it can be a treatment for night sweats and some hot flashes. It might reduce the sweating. It can be associated with some nausea or GI upset. The brand I tend to recommend is remifemin, and the German Commission E is similar to our FDA, and it approves the use of black cohosh for up to 6 months to relieve hot flashes. Now, rarely, black cohosh and other herbs like valerian root, which has been used for anxiety, have been associated with some reports of liver toxicity. So it's important to see your doctor and have blood work and be monitored. Soy isoflavones, plant-based estrogens found in soy foods, are thought to have very weak estrogen-like effects. I think it's better to choose the food as opposed to pills or powders. And you might want to go back and listen to the discussion that we had on soy isoflavones being converted into equal, and not too often actually in females. Evening of primrose oil. Some women say this botanical oil reduces hot flashes. Side effects can include nausea and diarrhea, and women with schizophrenia specifically should not use evening of primrose oil because it actually may worsen their condition. Flaxseed. This is certainly an important food to incorporate into your diet for overall health because the benefits of omega-3 are great on the brain and the cardiovascular system, and like soy foods, when it's used to replace animal fats, it might help lower cholesterol. And you can get flaxseed in whole seed and oil forms. Vitamin E. E is in Earl. Taking 800 international units of vitamin E has been advocated to help reduce hot flashes. And there was a placebo-controlled randomized study looking at 800 international units for 4 weeks in 120 women that were breast cancer survivors, and found that compared to placebo, it did decrease hot flashes slightly. And it's important to know that the brain is very potent, and placebo alone can decrease hot flashes by 30%. Scrutinize so-called remedies. The brain is clearly our most powerful organ, and it believes that if a remedy is helping, it will actually help the body feel better. As the saying goes, mind over matter. This is why researchers subject substances to placebo test, because one study group will be given the proposed remedy and the other one will be given an inert substance or placebo. And then the researchers record how each group responds. And often proposed treatments show really no better results than placebo because the placebos are very powerful. The power of suggestion is real. So when a woman says that she took a vitamin or a concoction from something or a compounding pharmacy and it reduced her symptoms, the question is, was it the power of her own brain or did the remedy actually work? So please choose remedies that have been subjected to some study, but also please realize how important the brain is. In fact, there was a very interesting study measuring strength before and after in a group of 3 groups of people. One that did exercise, one that was just told to think about doing exercise for a certain amount of time a day, and then another group that was the control group that was told to not do any exercise. And they measured the strength at the beginning and end of the program. And as expected, the people who did the exercise gained the most strength. But was equally and probably more interesting was that the group that just thought about exercising actually did gain a little bit of strength compared to the group that did no exercise and didn't think about it. And I tell my patients it's much better to exercise, but I know on some days when I'm running late and I can't get to the gym before work, I certainly think about intense exercise and sweating when I'm driving in my car. Now, again, that's not a substitute for exercise, but it just is a testament to how powerful our brains are. Alternative treatments can be a wise choice for women who have blood clots or women who've had estrogen-related cancers like active breast cancer or active uterine cancer, or women who are taking tamoxifen or undergoing other treatments. In general, for these particular women, the risk of hormone therapy may outweigh even short-term therapy. And other women simply prefer non-prescription treatments. Maybe they don't have any vaginal symptoms or they're on something locally. Maybe they already have excellent bone densities. Just remember, you should always discuss all therapies, even non-prescription drugs and vitamins, with your doctor or your nurse practitioner or physician assistant before taking them. So thank you so much for joining me, your host and author, Dr. Holly Thacker, in the Cleveland Clinic Guide to Menopause. Please give us a 5-star rating, and you can subscribe to our podcast. We have 3 threads anywhere that you get your podcast. And I'll see you back in the Sunflower House next time to talk about sleep difficulties and disorders.